everyone. I'm Dr. Josh Garibaldi, your friendly neighborhood medical science liaison with OTSCA. Thanks for joining us for the first of a two-part series on IgA nephropathy. If you caught our recent webinar, you know we dug into B-cell biology and immune dysregulation. Today, we're building on that foundation with a deeper dive into the pathogenesis and diagnosis of IgA nephropathy, and we'll bring in the latest KDIGO guideline updates along the way. I'm joined by two terrific guests. First, Dr. Yelena Drexler, Associate Professor of Clinical Medicine at the University of Miami, where she also serves as Director of Clinical Research in Nephrology and is a recognized expert in glomerular disease. And with us as well is Dr. Mark Richards, a nephrologist with Florida Kidney Physicians, where he leads the Glomerulonephritis Center of Excellence in Boca Raton. Between the academic and community lenses, you're going to get the full picture today. Think of it like stereo sound for nephrology. IgA nephropathy is unique among glomerular diseases because of its distinct immune mechanisms. The production of galactose-deficient IgA1 by plasma cells sets off a four-hit pathogenic process that culminates in immune complex deposition in the glomerular mesangium, which leads to kidney injury. Dr. Drexler, how does this immunologic profile differentiate IgA nephropathy from other glomerular diseases?
Thank you, Josh, and thank you to the Florida Society of Nephrology for having me. IgA nephropathy is considered a rare disease, but it is the most common primary glomerular disease, and it's a leading cause of chronic kidney disease and kidney failure worldwide. What makes it unique is its very specific immunologic signature, explained by the well-established four-hit model of pathogenesis. The central event in hit 1 is the production of abnormal IgA1 molecules, specifically galactose-deficient IgA1, by B cells at mucosal surfaces. In hit 2, the immune system recognizes these aberrant IgA molecules as foreign, leading to the synthesis of autoantibodies against that abnormal GAL-deficient IgA. In hit 3, IgA-containing immune complexes form, and in hit 4, these immune complexes deposit in the glomerulus, where they drive immune-mediated glomerular injury through the activation of pro-inflammatory and pro-fibrotic pathways. So the key takeaway is that this unique immunologic profile doesn't just define the disease biologically. It also provides a clear rationale for therapies that specifically target both the development of pathogenic IgA and the downstream pathways that lead to progressive nephron loss and ultimately kidney failure.
Thank you, Dr. Drexler. So over the past few years, there's been growing recognition that IgA nephropathy is not just a kidney disease, but a mucosal immune disorder, with APRIL playing a central role in that process. Dr. Richards, how do you see this link between mucosal immunity, APRIL, and IgA nephropathy shaping our understanding of the disease? And what does it mean for future approaches?
Absolutely. And thank you, Josh, and thank you to the Florida Society of Nephrology for having me today. A lot of the older approaches to management of IgA nephropathy were based on kind of attacking hit 4 that Dr. Drexler had alluded to earlier, specifically with RAS inhibition or more recently SGLT2 inhibitors that could protect the glomerulus from these depositing immune complexes formed from the production of galactose-deficient IgA1. In addition to protecting the glomerulus from the untoward effects of galactose-deficient IgA1 and IgG or IgA immune complexes depositing in the glomerulus, we now are focusing more of our attention on upstream production of the galactose-deficient IgA1 molecules. IgA is the predominant antibody that is released in secretory surfaces, such as in our gut-associated lymphatic tissue. We know that this is regulated by B cells. However, what's interesting is that older analysis of depleting B cells, such as with CD20 or CD19 depleting agents such as rituximab, actually were not able to reduce proteinuria or reduce Gd-IgA1 levels in patients with IgA nephropathy. Therefore, a potential different source of autoimmunity was necessary, hence APRIL. We now know that APRIL levels are increased in IgA nephropathy. Potentially blocking the release of APRIL could be very useful to the management of patients with IgA nephropathy.
Thank you, Dr. Richards. One of the trickiest things about IgA nephropathy is just how variable it can look in practice. Some patients may only show microscopic hematuria for years, while others present with rapidly rising proteinuria. So Dr. Drexler, how do you decide which patients require closer monitoring or earlier referral? And how do KDIGO's updated risk tools help guide those decisions?
You're absolutely right. IgA nephropathy is highly heterogeneous. Some patients may only have microscopic hematuria for years, while others already show significant proteinuria and nephron loss by the time they're diagnosed. So in fact, the majority of patients with IgA nephropathy are first diagnosed at CKD stage 3 or later, often with significant glomerular inflammation or even fibrosis already present on kidney biopsy. Now, if that glomerular inflammation is not diagnosed early and effectively treated, it leads to irreversible nephron loss, which is why early recognition is so important. And the new 2025 KDIGO IgA nephropathy guideline really underscores this point, and it emphasizes that proteinuria remains the only validated early biomarker to guide clinical decision-making in IgA nephropathy. Large studies, including data from the UK RADAR cohort and others, confirm that patients with proteinuria above 0.5 grams per day are at risk of progressive loss of kidney function. Those patients should be treated early to prevent irreversible nephron loss and to hopefully prevent kidney failure in their lifetime. Now, because IgA nephropathy can only be diagnosed with a kidney biopsy, and because early diagnosis and prompt treatment are so crucial, I strongly consider biopsy in all adults with proteinuria above that 0.5 gram per day threshold. I think this approach allows us to make an early diagnosis, stratify risk appropriately, and initiate targeted therapies before irreversible damage occurs.
Thank you, Dr. Drexler. So when we do get a biopsy, one of the most powerful tools at our disposal is the MESTC or MEST-C score, a structured way to predict risk based on histology. Dr. Richards, could you break down the MEST-C score for us, what each element captures, and how it shapes your risk assessment?
Absolutely. So, as Dr. Drexler had alluded to earlier, we cannot diagnose IgA currently with any available biomarkers. We have to perform a kidney biopsy on these patients to confirm this diagnosis, typically in patients now who have proteinuria greater than 0.5 grams. And on the biopsy, we now have what's called a MEST-C score that can help us classify the severity of a patient's IgA nephropathy. In addition to providing us with the diagnostic value, we can also gain prognostic value for our patients. Specifically, the MEST-C score was created in 2009 after a meeting of the International IgA Nephropathy Network, and it created the specific Oxford classification. So M stands for mesangial hypercellularity and is scored between M0 and M3 based on the number of cells in each mesangial component. E stands for endocapillary hypercellularity and specifically looks at the amount of cells in glomerular capillary lumens, and that is scored between 0 and 1 based on their absence or presence. S refers to segmental glomerulosclerosis, which could be a marker of more chronic injury. And again, that is scored between S0 and S1. And then another marker of chronic wear and tear and irreversible damage is the T component, which is tubular atrophy and interstitial fibrosis. And that can range from T0 to 2 based on what percentages of the extraglomerular compartments of the nephron are sclerosed. Finally, C refers to the presence or absence of crescents or fibrocellular crescents, which could suggest a more active or aggressive form of IgA nephropathy. These scores can be very useful as they have actually all been shown to be predictive of the time course of our patients with IgA nephropathy. Specifically, there has been the creation of a risk prediction tool that can actually estimate the 5-year risk of a 50% decline in kidney function or the development of end-stage kidney disease requiring renal replacement therapy. And this is actually looking at data from the kidney biopsy based on the MEST-C score, as well as clinical data up to 2 years after their biopsy. The one caveat is that specific risk prediction tool did not account for the presence or absence of hematuria or the presence or absence of crescents. So patients perhaps with more aggressive levels of kidney damage, their severity might be underestimated here.
Thank you so much, Dr. Richards. So, as you both have alluded to, biopsy remains the gold standard for diagnosis. But the field is moving quickly with non-invasive biomarkers and new risk calculators. KDIGO acknowledged this evolution in their 2025 update. So, Dr. Drexler, where do you see the balance heading between biopsy and non-invasive tools in the coming years?
As we've said, again, biopsy still remains the gold standard for diagnosing IgA nephropathy, and this is for several reasons. So first, IgA nephropathy can only be definitively diagnosed with a kidney biopsy, as we don't yet have validated serum or urine biomarkers for diagnosis. Second, it allows us to confirm glomerular IgA-containing immune complex deposition and evaluate the histologic features, as Dr. Richards so well highlighted. And third, in this new exciting era of targeted therapies, a biopsy-confirmed diagnosis of IgA nephropathy is required to justify and guide treatment with these newly approved and upcoming therapies. So biopsy is really crucial. And in addition to diagnosis, and I think equally important, biopsy provides the foundation for prognosis. So as Dr. Richards mentioned, one very helpful tool is the International IgA Nephropathy Prediction Tool, which I do use. I think is very helpful for shared decision-making with patients. As was stated, this tool integrates both clinical data at the time of biopsy, including age, eGFR, proteinuria, blood pressure, and whether the patient is on ACE inhibitor or ARB, together with histologic findings, which is that MESC score, and whether the patient is on immunosuppression at or prior to biopsy. And that allows us to estimate that risk of a 50% decline in eGFR or kidney failure at specific time points after biopsy. But ultimately, though, I think it's still very important to interpret these results in the context of the biopsy itself. And that helps us distinguish whether patients have a predominantly inflammatory phenotype or whether they have significant fibrosis or potentially somewhere in between. And that information, I think, is very critical because our treatment strategy does depend heavily on the balance of active inflammation versus chronic scarring seen on biopsy. But I think it's also very exciting to consider the future for non-invasive tools in the coming years, especially with newer targeted therapies and the potential for markers such as measures of galactose-deficient IgA1. But I think this is something that we should look forward to in the future as it's not yet validated for clinical use.
Thank you so much, Dr. Drexler. And that wraps up part 1 of our IgA nephropathy series. Thank you to Dr. Drexler and Dr. Richards for breaking down both the science and the art of diagnosis. Stick around. In part 2, we'll move from diagnosis into what to actually do about it, management, monitoring, and the road ahead.